guest here. She is a master holder and a PhD holder in endodontics from Yeditepe University. And she's now a faculty member and PhD program coordinator in the Yeditepe University. She has had the experience of evidence-based dentistry training from the Oxford University and is now a visiting faculty member of University of Toronto. And currently she is on the sabbatical role in Louisiana State University, New Orleans in the United States of America. She is a pioneer in microdentistry in Turkey, and she has lots of scientific publications and book chapters in endodontics. And now she is currently editor of an endodontics section of European Oral Research Journal. So we have lots and lots of prides on her side, and it's our great pleasure to be with her today and tonight, actually, in the United States. So the stage is yours, and we are all ears to have your lecture today. So I cannot be happier than this to be here.
First of all, thank you very much. I would like to extend my appreciation to you because you invited me to give a lecture for your distinguished department, distinguished, valuable residents. I really feel honored and excited. I don't know if I can tell anything that they don't know. Probably I cannot. And also finding me the topic and choosing the appropriate time, really, I couldn't make it if I wouldn't have your support. Thank you very much.
You're welcome.
Okay, so how many residents do we have as audience here today?
We are all here. Not all of our, but I'm not sure whether they are present in the room, but they have your face and your slides and your video from their TV, so they are all listening to you. But of course, the announcement has been publicized all throughout Iran, and we may have lots of guests from different universities nationwide. For example, we have 2 or 3 at least dental schools in Tehran, and they are all eager to listen to your lecture today. But I'm not sure whether they can interact or they have comments in the room. I'm not sure. But I'm sure they will listen to you and they will record this session.
Okay. Thank you very much for letting me know about the audience as well. So I am Meriç Karapınar Kazandağ. As Dr. Assadian introduced me, I had some research. One of them is very important to me. We published it together with Dr. Nekofar, and our friendship started with this. Actually, we published it in 2009. However, we started to collaborate to publish this 4 years before, when my first child, my daughter, was born in 2005. So, which means that we know each other for 20 years. Actually, this is a humble CV of mine that you already told me. I just want to say that I was the coordinator of the program. I am not anymore. And also I was a visiting faculty of University of Toronto, but it was 2007 and not currently. So just to the young people, I don't want to know the mistake, correct it. Just they may think a different thing. And that's, yeah, I am at the Louisiana State University, yes. And this is Dr. Nekofar and his lovely wife, who is also a friend of me. And we have much more pictures apparently, but I couldn't fit them all here. And here you are, Dr. Assadian, in our joint meeting. Do you remember? During COVID time, we had a meeting, Tehran University of Medical Sciences and Yeditepe, and you are here.
Oh, yeah, I remember that.
Do you remember
yes.
that meeting?
Yeah.
And this is Dr. Nekapar with various meetings. We were together. And what do? I am an endodontist. What can I do? I do the non-surgical endodontic treatments and surgical endodontic treatments all the time. And I teach on, similar topics and gave some hands-on courses, some specific topics. And these are my area of interest, basically. And I come from the city of Istanbul. I am sure majority of you already has visited, very close to Iran. And our culture, shopping, views is very similar to Iran.
Yes.
And this is Yeditepe University main campus where I work. This is like 1 hour or half an hour away from the Faculty of Dentistry, which is located in the downtown. And which we're proud that we get CODA accreditation from United States in 2024, which means that since then our graduates have a diploma accredited in the United States and they don't have to take an advanced standing program to practice there. And this is the lovely department that I work. We have 15 residents currently. And this is 3 days ago, there was Halloween here, and some of the faculty, as their scary dream, was in disguise, wear the costumes of CODA auditors. And I sent it to my friends in the CODA committee in Turkey. You see, this is not the only our horrible dream, having an audit from CODA. So the schools in the United States feel in the same way. And after working hard in Yeditepe University for more than 20 years, I decided to rest a little bit under the oak trees and came to the United States, to the state of Louisiana, which is located near Gulf of Mexico. Now we call it Gulf of America, you know.
Yeah.
And in the city of New Orleans, located in New Zealand. The nickname of city of New Orleans is connection good, Dr.
Yes,
Assadian?
yes, perfect.
Can you hear
Yes,
me
yes,
okay?
perfect.
Nickname
Yeah.
of city of New Orleans is Crescent City because of Mississippi River makes a crescent in the downtown of the city.
So that's
And
why because it looks like a curve in the root canal. So you chose New Orleans for being for living, right?
yes, you are very right. But there were some other reasons for choosing New Orleans. New Orleans is famous for parades, right? Rio Carnival, and also famous with jazz music because jazz music was invented in this city, and because of that, their only unique and small international airport is named after Louis Armstrong, which is a famous trumpet player. And jazz music is so important. This is a funeral from New Orleans. So different than our cultures, they don't cry for the person who died. They do music and celebrate the second life of the dead person. And what is also different than our cultures, Iran and Turkey, is food. They eat a lot of seafoods, and this is a natural picture from Museum of Arts. So it is very important for the city, and they eat a lot of seafood. And my husband and son enjoys American football. This is Louisiana State University. Main campus is located in Baton Rouge. This is another city 1 hour and a half away, but they have a huge American football stadium. Student body is, you see, 40,000 people. However, stadium capacity is even twice bigger than that. So, which means that guests are welcome to watch the games. And the School of Dentistry is located in New Orleans, and this school is the only unique dental school of whole states.
Wonderful.
Yeah. And of course, football craziness continues in dental school as well. And this is our head of department, Fred
Oh my gosh.
McMullen, giving a smile with the footballer in the classroom of dental school. And this is me giving the same kind of smile. But if you take the football player like a reference, you'll see the size of people here a little bit bigger than me. And this is the lovely department that I work here. We have 8 residents actually, but one thing here is taking the picture. That's why Max is not here in the picture. This is Chip Simon, which is one of the former presidents of American Association of Endodontists. And this is Dr. Arch and other full-time faculty from our department. And these are the dental students who are interested in endodontics, and they are also welcome whenever they have time to listen to seminars and to understand what they are intending to go into. And their program is very popular. They received more than 250 candidates for the 4 positions each year.
4 positions each year.
For every year they have, because this is a 2-year program for graduates and for newcoming people. This is the postgraduate part of the endodontic department, and they have 8 global microscopes. Unfortunately, in Yeditepe, we don't have 15 microscopes for each of our residents, so I'm a little bit jealous about this. And in addition to that, they have 2 Zoomax. But for the globals, they have their own monitors, which I like because it's easy to supervise. We can see what they're doing through the monitors, and it's convenient for us. And plus, with the wheels, but they have 2 Zoomax. They recently bought it, and they have 1 Zeiss. And also, nitrous oxide is very popular here. They have 4 very old, but working nitrous oxide machines, especially for pediatric dentists. They use it every day. In Turkey, as dentists, we are not allowed to use nitrous oxide. And
same here in Iran.
Same here there, right? But here, my understanding is they have a little education for a few days, and then they are authorized to use these devices. And what is they have 2 gentle waves donated by one of their alumni. So they enjoy to use it as well. And if we come to the pain issue, we will talk about a little bit importance of taking the pain history, and then we will talk about how to improve inferior alveolar nerve blocks and identify, select, and most effective strategies for managing postoperative pain. And a little bit talk about corticoids, and less than that, we will talk about cryotherapy, which is popular nowadays. Why do we talk about pain so much in endodontics? Because endodontic treatments are more frequently associated with pain than the other dental procedures. And in terms of endodontics, listening means taking the history of the pain, observing and verifying is corresponding to clinical and radiographic examination, and elimination is treatment. Story of the pain should also include the trauma, previous interventions, as well as the bruxism. This comes from the literature, of course, but as a clinician, my humble opinion, it is important to use that. Do you have bruxism? Patient may say yes. Did you have treatment? Do you have your splints? The answer is yes. You should also ask, do you use your splints? Usually they don't. My humble opinion, I think this should be at the literature. And open-ended questions were shown to take us to the target in a shorter time. However, they may not be enough in our cases, and they may need a more structured way of asking the story of the pain. So first, First question, again, my humble opinion, should be what is the chief complaint? And intensity of the pain out of 10. And where is it? Location. Of course, the patient may locate in a wrong way, but this is the third question to be asked. Duration of the pain, as well as if it is more intense day or night, what is the frequency of the pain can be helpful. Also, we should try to learn if there are any aggravating or elevating factors. Patient usually tell this before we ask. If we cannot still find out, we can ask the question how, but this is very tricky because the patient may look at you like a rabbit. How? What is that? If this is the situation that you have, you can say a little bit structured, maybe, is it sharp? But I suggest not to give so many clues, but you can say that what you are expecting, like throbbing, stabbing, if you give some clues, if there is a situation to tell, patient usually tells you. At this point, the key decision point, if the pain is odontogenic or not. And this is my colleague. This is a chapter that we translated with my colleague Elif Delve Başarcan. It was a long chapter, but we learned a lot this. And this is Elif Delve here. She also contributed our joint meeting with Tehran University. And
Yes,
differentiation of, you remember her, right?
Yeah.
Differentiation of non-odontogenic pain. There is usually no apparent etiology for pulpal or periradicular pathosis. It is spontaneous. It is poorly localized or migratory, constant and non-variable, usually, and it can be burning, pricking, and shock-like. If the patient says this, you are very lucky. Yeah, so these are not likely odontogenic pain symptoms. Thanks God that research shows that only 3% of the patients are diagnosed with non-odontogenic pain, and 3% of the patients who refer to endodontists are diagnosed with non-odontogenic pain. So, which is not frequent, but still we have to deal with that. And this pretty lady has a sad story on my end. Her chief complaint was the persistent pain in lower left jaw for 4 years. Severity is 3 to 4 out of 10. What happened? Because of the pain, tooth 37 had root canal treatment. Pain had a temporary relief, however, came back. Upon this, tooth 37 was extracted. A temporary relief again, and the same story repeated with number 36. Root canal treatment, temporary relief, extraction, temporary relief. And the patient started to feel the pain in 35 and the same story. Now she lost all of his molar teeth as well as a premolar teeth, but the pain is still here. Now she feels the pain at 34 and wanted to ask my opinion if everything is all right. Of course, everything was not all right. Probably from the beginning, it was not an odontogenic pain, and because all of the remaining teeth were tested within normal limits. Only this, 34 had a percussion sensitivity at some degree, which is very normal for a premolar taking whole occlusion on it. So she was referred to neurologist with a suspicion of trigeminal neuralgia. And this 74-year-old Indian origin male patient was the first patient of mine in United States. And the patient had two fillings, two composite fillings close to pulp, and a pain started afterwards. This happened like 1 month ago. And the prosthodontist, because here in the school LSU, prosto and resto are together. I don't know if Tehran University do the same. They call it prosto, and they do all type of restorations, fillings,
Yes.
onlays, crowns, right? But in
Yeah.
Yeditepe, in Turkey, restorative dentistry, who does the fillings and onlays, and prosthodontics is different. So it was one of the different things for me. Okay, the prosto made two fillings and the pain started afterwards. The patient was referred to me. Referral reason was the third molars, upper third molars. I don't know if you can see, you see it, right? Because on the right, I see, excuse me. There's a problem. Now I lost my, I lost my screen. Dr. Assadian, please help me. Zoom put your picture in the middle of the screen and I cannot see my screen, my presentation anymore. What? I don't know. Let me go and come back. Okay. Let me try this one. Okay. Do you see my screen? Do you see my screen now?
No.
No. Oh my God.
There is an arrow at the middle of your page, upward arrow. Underneath this arrow is written share, so you can share your screen over there.
Yes, I did, but
Oh, now we have it.
okay. Okay. This to make a long story short, the prosto wanted me to do the root canal treatment for the third molar, upper third molar here, and the lower third molar here. Sorry for the resolution, but this was the initial radiographs. There were composite fillings here. So I made my own examination, and I figured out that there is a percussion sensitivity in the second molar, upper second molar, and third molar here and the third molar here, percussion sensitivity and exaggerated pain to cold. However, the patient was coming from Baton Rouge with the brother, with the son-in-law, so they say that they don't have much time in New Orleans. So I chose this one because it was more exaggerating percussion sensitivity. I do the root canal treatment. I mean, the canals were very calcified. I could only, put one cone inside of them, but put a poor filling on it because the gagging reflex and the nervous patient and whatsoever. But I was happy with the result actually for this tooth. And what happened? The pain was over for one month. And when I made a follow-up, there was no problem. I was surprised because I was waiting some pain because of this second molar and the third molar. They had percussion sensitivity and cold sensitivity before, but the patient was happy. So there was no problem, let's say. I couldn't make a follow-up, but I thought that no news is good news because son-in-law did not reply to my emails. And when I was in Turkey for vacation, the patient came back to school. One of our residents independently made examination and decided that the source of the pain was the second molar here, and did a root canal treatment, which is radiographically better than that. And the patient was happy for 1 month. But the pain came back as 10 out of 10 again. And I did a root canal treatment in the third molar because There was no percussion sensitivity and cold sensitivity in this tooth and as well as this tooth, but this had a percussion and cold sensitivity. I did a root canal treatment. The patient was fine for 1 month, but the pain came back as 10 out of 10. So now the patient says that there is pain in this tooth, cold sensitivity, percussion sensitivity, but this time I hesitated because I had a suspicion of phantom pain because it was migrating. And the prosthodontist make an occlusal adjustment to this tooth, and the patient is happy now. We hope that the pain is over, but actually I have concerns about it because this seems to be a migratory pain to me. One more patient about non-odontogenic pain. And this is an interesting case. Another patient referred to me from the pain department of LSU. All pain history started with the root canal treatment to this number 11, 1.5 years ago. And interestingly, it is radiating from 3 teeth, 11, 13, and 14, because 12 is missing. And it is exaggerated, originating from them. This is what patient says, radiating to face and skull. And it is intensifying under shower, and there is a temporary relief when the patient is brushing the embouchures with interdental brush. This is what he says. There is a very old filling here, more than 30 years, this says, and the old crown here, and an implant. He has no problems with them. There is some little percussion sensitivity. And actually, of course, pain department told about the neuralgia, trigeminal neuralgia, but they say that there is a sensitivity when they touch with the explorer, and there is a little catch here. That's why I took a CBCT, and I saw a less crack-like thing and a little bit deeper pocket here. However, I concluded that this cannot be the reason, radiating to the skull and intensifying with the shower and so on, which is the primary things. You know, neurology always want us to eliminate all odontogenic things. If we are sure that it is non-odontogenic, send the patient to them. But this time, I wrote a referral letter to them and say that this time, neurology should eliminate that it is not neurologic and send the patient back to us, because the localized pain can be coming from that little crack, maybe, but this is not the primary, this is not the chief complaint. So we cannot address this, although it started with root canal treatment. And I don't know what happened. I think neurology got the message. And identifying the offending tissue, if it is odontogenic pain, it can be pulp or periapical tissues. And in this case, the painful diseases of the pulp are reversible pulpitis and symptomatic irreversible pulpitis. And the periapical ones are symptomatic apical periodontitis and acute apical abscess. But as this is a very, very large topic, today we're going to talk about symptomatic irreversible pulpitis. And out of the treatment options, we will talk about non-surgical root canal treatment and a little bit about vital pulp therapy. The others will not be discussed today. And this is a chapter that I wrote together with my dear friend, Dr. Kaptan, and who is also a very good friend of Dr. Nekofar. They spent 1 month in UK when Dr. Nekofar was working in Cardiff University. We again visited him for 1 month, so they are very good friends. This is a chapter that we enjoyed to write very much and learned a lot when we are writing, because non-surgical root canal treatment and of course all endodontic treatments require local anesthesia. And achieving successful anesthesia, as we all know, is harder in mandibular molars. Why? Because there are 2 anatomic reasons, mainly because nerve trunk is embedded in the thick cortical bone. So infiltrative anesthesia does not work for these teeth. And also, according to central cord theory, fibers innervating the molars are located in the periphery of the nerve trunk, which makes it difficult for local anesthetic solutions to diffuse these fibers. This is a theory. However, interestingly, in patients with normal pulp, success rate is 75% to 85%, which is not very low. However, on the other hand, in patients with irreversible pulpitis with the same anatomy, success rate is 23 to 24%. This is for lidocaine, this is for articaine. What is happening in reversible pulpitis? First of all, there is inflammation. And inflammatory mediators sensitize the C nociceptive fibers, which are the primary nociceptive fibers in the dental pulp, reducing their pain threshold and causing exaggerated response to normal stimuli. And another phenomenon we have here, prolonged nociceptive input to secondary and primary analgesia is usually addressed with non-steroid anti-inflammatory drugs and corticosteroids. But secondary hyperalgesia, prolonged nociceptive input to second-order neurons and higher brain centers in irreversible pulpitis induces central desensitization, further sensitizing peripheral nociceptors. And we have some central activating drugs, which we hope work for this phenomenon. So, with the residents, if you don't mind, can you open your Hopperlers, like voices, audios, and answer my questions? This is like a trivia just to have fun. I know you know the answers, but to make it a little bit interactive. Can you open it? Just, does the numbness in the lip indicate pulpal anesthesia? What do you think? Come on, I know we have some residents here, not all of you, but just to have fun. You will say yes or no. Who cares?
I'm not sure they can answer. I'm not sure. Let me.
Maybe they're not allowed to open their microphones?
No. But the type of their connection is so that they cannot, I think they cannot participate as you want. They cannot answer your question. Just they can visit your slides and hear your voice, I suppose.
Okay, I understand. Okay, no worries. The answer is irrelevant. Of course, it is not. And does soft tissue numbness indicate pulpal anesthesia? No, it's irrelevant. Can pulpal anesthesia be checked with cold? So how will we decide, right? The answer is yes, we can do that. Can pulpal anesthesia be checked with electric pulp test? Yes, but we need 2 consecutive tests at least 2 minutes apart. Some of the studies use this method and some others use the cold test. And does speed of injection matter in the success of inferior alveolar nerve block? Yes, it does. 60 seconds is better than 15 seconds. And also, slow injection causes less injection pain. So let's make it slow. Do you see, does the angle of administration matter? I mean, the needle, because we taught like this, right? You should be parallel to the ramus of the mandibula and you should be vertical, and afterwards you give the injection. Does this matter if the needle is vertical or parallel? Does this matter? What do you think? No, this is another question. Sorry, I cannot see whole my my whole screen. So does it matter if you put it in the correct place? Yes, of course it does. However, anesthesia may not be achieved even though the solution administered exactly where it has to be. So it matters, but it does not guarantee. So does the angle of the needle matter? Now the question is, I like this question more, I think so. And whether it's parallel or vertical to the ramus. No.
So there is
It's
no difference
irrelevant.
between direct and indirect nerve blocks that we used to learn in the past. That they can have equal results, right? Am I right?
Yes, exactly. As soon as you go into the pterygomandibular lodge, it doesn't matter if it is parallel or vertical. And does tube type matter in the success of inferior alveolar nerve block? Yes, it does. 17% of molars, 11% of premolars, and 32% of anterior teeth cannot be anesthetized with inferior alveolar nerve block. So it matters. Thanks God that despite of high failure rate, we have infiltrative anesthesia for anterior teeth because they don't have thick cortical bone there. So management. So how can we manage, how can we address this problem? We have methods that we can apply preoperatively, we have methods that we can apply intraoperatively, and we can do some other postoperatively. Perioperative pain management. This is a review that I wrote with my dear friends Jale and Handan. They are also friends of Dr. Nekopar. I couldn't find their pictures together, but this is a well-cited review. I am very happy that I wrote it. And we had basically 8 conclusions out of this review, and we will go through them. Non-steroid anti-inflammatories prescribed 1 hour before the treatment increases the success rate of inferior alveolar nerve block. And at this point, non-steroid anti-inflammatory drugs are more successful than paracetamols. So why do we need the paracetamols? We use them because non-steroid anti-inflammatory drugs are sometimes contraindicated. What can we do 1 hour before? Do else 1 hour before? We can inject magnesium sulfide inside of inferior alveolar nerve block to the same place 1 hour before the local anesthesia. So this increases the success rate from 32 to 60. I want you to give you an insight because don't forget this. I will show you many methods now, and you will see that they always have a similar effect. They increase from 30% to 60% somehow. If you have only 30 minutes, what you can do? You can give intraoral ketamine, and this before inferior alveolar nerve block. So this reduces the number of cartridges. In this study, interestingly, they measured the number of cartridges they use it. And they say that it increases the success rate of inferior alveolar nerve block and decreases the postoperative pain. So that's why there is no percentage here. If you have only 10 minutes before inferior alveolar nerve block, what you can do, you can inject tramadol, which is an opioid analgesic, as buccal block here, and it increases from 30% to 60%, more or less, the same effect. And it is before articaine. Increases this study used articaine. And anxiety is often closely linked to painful stimulus, increased pain perception, and thus more exaggerated pain experience. More pain that lasts longer. Moreover, they also exaggerate their memory of pain. I don't know if Dr. Assadian also agrees this, but as a clinician,
Yes,
I agree.
definitely. And there are some psychological background behind this, because when you have anxiety in your patient, you have increased heart rate, you can increased blood pressure, you can increase chance of local anesthetic washout from the environment. You may have vasoconstriction, and there are lots of underlying mechanisms that can block or mitigate the effect of your local anesthetic over there. For sure, definitely, if you have an anxiety reduction protocol for your patient, you can have increased success rate for your local anesthetic injection.
Yes, I totally agree. And this is a patient, chief complaint, pain in the lower right jaw. Severity is 10 out of 10. History, the pain started shortly after cementation of fixed dentures 1 month ago. Patient recently divorced and wanted to make a change in his life, and she decided to do the new bridges and the crowns and aesthetic things in the mouth. And because the patient felt the pain in tooth 46, RCT was done by the dentist. However, the pain worsened. And the tooth was extracted because the patient thought that the pain was unbearable. However, even worsened. And the patient could not sleep for 3 days before she visited me. And all teeth were tested normal in the mouth. And I decided, actually, I consulted with TMJ specialists too, and we decided to prescribe Xanax 0.5 milligrams, which is an anxiety medication. This decreased the pain. And I referred the patient to a TMJ specialist. Probably they will collaborate with a psychiatrist as well to manage it, because it started probably with the occlusion problem and turned into a muscle problem, and the things become confusing actually, but mainly it was a matter of anxiety. And highly correlated, dental anxiety highly correlated with pain felt during and after operation, which means that if you have fear, you feel more pain. Intraoperative pain management. Although a recent review, 2023, says that there is insufficient evidence that pharmacological control of the anxiety can influence intraoperative pain occurrence, actually nitrous oxide, as I told you, that it is very commonly used here. Nitrous oxide also scientifically has shown that it increases the success rate of inferior alveolar nerve block. And this is our head of department who likes this methodology and let the residents to learn and enjoy it every day. And Buffer Pro is, I don't know if you have it in Iran.
No.
It is popular in the endodontists in the United States. That's why I read about it. But according to my understanding from the literature, actually it decreases the onset time of the local anesthetic, so you don't need to wait that much. It decreases the postoperative pain. It increases the duration of the local anesthesia. However, it doesn't have any effect on the success rate of inferior alveolar nerve block. Although the endodontists prefer to use it, it is not very cost effective. It increases a little bit. So use it for nerve blocks, and they believe that it increases the success rate. But until now, there is no, I think, I couldn't find any literature to support this idea. And another question, does vasoconstrictor matter? I mean, does it increase the success rate of inferior alveolar nerve block? What do you think? What do you think, Dr. Assadian?
I think so. I
As a
think
clinician, you think so, right?
as a clinician, without any reliance on any evidence, I can say that local anesthetics with vasoconstrictor are usually more effective in profound anesthesia in comparison with those who do not have vasoconstrictors in their incorporation. But actually, it's something just based on my experience, and it's not scientific.
And according to this literature, which is in the guidelines, same palpal anesthesia effect for 50 to 55 minutes, with or without vasoconstrictor. Same for stenous, same for mepivacaine. These are plain. This is irrelevant. However, and as a clinician, I agree this idea. To me, it doesn't increase, okay? However, if you look at from another side, another literature says that lidocaine with epinephrine is better than plain mepivacaine in terms of success. However, to make my presentation shorter, I removed that slide, but now I regret. There is another research, I think this is it was very well designed, showing that if they had the same amount of vasoconstrictor, they had the same potency, which means that 2% lidocaine, 2% mepivacaine, mepivacaine is more successful. However, in this research, they use more potent mepivacaine without vasoconstrictor and lidocaine with epinephrine, and epinephrine is more successful, which suggests your opinion. And majority of the endodontists thinks like you. They think that with epinephrine it's more successful.
Of course, in some rare cases, I have had an experience of failure of anesthesia after injection of lidocaine with a vasoconstrictor. And then I administered another type, for example, a cytonest, which incorporates felipressine and I mean a different type of vasoconstrictor. Then I had a success. So it can be because of the the drug response act. I mean the drug and the response of the drug that may differ from patient to patient. But actually, it's not based of science. It's not based of evidence. It's just based on experience, and it's just an experience of one or two patients, no more.
I understand. So lidocaine with epinephrine, they reported that 32%, because it changes from, I mean, this is under the conditions of this study, let's say 32%. However, epinephrine is not heart friendly and increases the systolic blood pressure and heart rate. So what can we do? What they do, they added clonidine, which is a hypertensive drug, to plain lidocaine. And you know what happened? Success rate increased to 60%. Very interesting, right? So whatever you do, it increases from 30% to 60%. And adding clonidine, surprisingly, did the same effect. Does increasing the amount of vasoconstrictor improve success rate? Very interesting question, I believe. Because in Turkey, we don't have epinephrine with higher epinephrines, 1 over 50,000 epinephrine. We don't have it in Turkey. Even for surgeries, we use 1 over 100,000. But here in the United States, they have it. They have long-lasting and local anesthetics, and so they can test it as well. So the question is, if you increase the vasoconstrictor rate, does your success rate increase? What would you say?
Of course, we do not have the chance to test this in Iran as well.
Same
because,
me.
Yeah,
Similar.
Because the concentration is constant, even from different pharmaceutical companies, and different products have the same concentration. So we cannot have, it's not possible for us to have such a comparison in Iran.
Yeah, but the
So
answer
I
is,
don't have any idea.
I agree, same for me. And scientifically, the answer is no, it's irrelevant. So there is no need for the success rate to improve the success rate. There is no need to increase the vasoconstrictor amount.
But
Thus, repetition.
how about the duration? So we just it's a belief that adding vasoconstrictors can increase the duration of anesthesia,
They do.
not the potency or the depth of anesthesia. So if so, I think the reason why we add a vasoconstrictor is not because of the depth; it's because of the duration.
True, you are very correct. They increase the duration of local anesthesia and they increase the hemostasis. So doing surgery with them is very comfortable. In most of the times, you don't need an extra hemostatic agent. It's comfortable. But although I mean, increasing the success rate of inferior alveolar nerve block is not our primary intention. As you told, and as the second literature I showed you, local anesthetic lidocaine with epinephrine is better than plain mepivacaine in terms of success. So which means that vasoconstrictor may have an effect, and many clinicians think that. So increasing the amount may have an effect, additional effect, but article says no, irrelevant. So, however, but now our question is, does repetition of inferior alveolar nerve block improve success rate? No. However, second inferior alveolar nerve block does not improve the anesthetic effect, but the patient may be experiencing slow onset of the first injection. Because we need 5 to 9 minutes for lip numbness. However, 15 to 16 minutes for pulpal anesthesia. You know, we are all becoming impatient because our life is faster than before. We have smartphones and everything. But to me, endodontists are the most patient specialists in the dentistry, even more patient than the GPs and every other specialty. And when you say this to oral surgeons, they became like very surprised and they think that this is so unnecessary to wait 15 minutes because they can extract maybe 2 more tooth in this time. But they can
Time
do.
is money, actually.
They are right. They can do, but achieving pulpal anesthesia is something different. You can extract the tooth, but you cannot take the pulp out if you don't have the pulpal anesthesia. So you need to wait 15 to 16 minutes for pulpal anesthesia to make sure that your first injection works. Even you wait like this, 12 to 20% of the patients need more than 15 minutes to get numbness. You know, my mother is a dentist, and it was a common practice in their generation. They do the inferior alveolar nerve block and took the patient out, take another patient in, do extraction or some simple filling, and take the first patient in with the inferior alveolar nerve block, and they do the procedure, root canal treatment, whatever they want. This was very common practice. And when I was in the school, I was very surprised because now I understand that my mother was right. As, you know, after a certain age, we all understand our fathers are right, our mothers are
Mothers are
right.
always right, yeah.
But you need to become a little bit more mature to understand this fact. And in my case, it happened the same because I read that 8% of the patients need more than 30 minutes to get inferior alveolar nerve block to achieve it.
More than 30, that's surprising.
Yeah, but only the 80%, but still somehow. But if you use the method of my mother, it works all the time.
Yeah, but you know,
Majority of the cases.
patients are always in a hurry and they want to go out very soon because they're having very tough time in dental setting. You know, they have to go out and they just need to be to get rid of this dental stuff and things.
Yes.
That's
Exactly.
what they really pose us to make it shorter and more summarized.
You're right. I agree. Does increasing the amount of local anesthetic agent improve the success rate? Now we are increasing the volume of it. What do you think? At the same time, you are doing 2 cartridges instead of 1. Does it increase the success rate?
Well, I think so.
Yeah, the
I
answer
think it
is
does.
yes. The answer is yes. And here in the United States, at least in this department, I cannot generalize because I didn't see the other departments in the United States. What they do, which was surprising for me, they give kits for root canal treatment to the undergraduate student, and these kits contains 2 cartridges. So they're allowed for inferior alveolar nerve block. They are doing 2 cartridges at the same time, even an undergrad. But in Turkey, what we do, we are so cautious. We give only 1. We want to be sure that they wait enough. And afterwards, they get 1 more with the signature of the instructor. But according to this article, what they do here is correct, seems to be. Yeah. Supplemental injection techniques. Does a supplemental milhioid injection help? Not really. Not really. And buccal, and actually there is to me there is enough accumulated evidence to show that buccal or lingual infiltrations do not result in complete pulpal anesthesia for mandibular molars. However, a more recent article published 2025 this year says that articaine alone for buccal infiltration, used for buccal infiltration, may represent a promising alternative to the traditional inferior alveolar nerve block in dental practice, which is surprising to me. And articaine, it is not very commonly used in Turkey. Even in our clinic, we don't have it. I don't know if you can get it, if you order it. I don't know, but I was not interested before until I read this. In United States, they use it and they think that it's very fantastic. Since now, I didn't see many difference in my clinical practice, but they like it so much. And this older article actually supports the newer one because it says that after following a articaine inferior alveolar nerve block, followed with articaine buccal injection is better than if you do the same buccal injection with lidocaine. Actually, it's supporting the newer one.
This article is written by my friend, Omid Diyanat.
This Ashraf? This one?
Yes. Yeah, no. This Dr. Ashraf is our colleague in Shahid Beheshti University, Dr. Kazan as well, and also Omid Diyanat is now in the United States.
Which university?
I'm not sure. Michigan? Michigan.
You know what? Actually, to be honest with you, I'm giving this lecture for many years, updating it almost every year and reading it. But until this previous one, this one published, I was thinking that honestly. This is very tricky. This article cannot claim that articaine is better than lidocaine because this buccal infiltration doesn't mean anything, right? Because this is a support, and it only means that articaine is better than lidocaine in the buccal infiltration. This was other thing. But when this is published, it says that alone it can be a promising alternative. Then the pieces of puzzle makes more sense to me.
So that's probably because of the point that penetrability of articaine inside bone trabeculation is stronger than lidocaine. That's because of the probably to my idea it comes like that. Probably the reason behind it is something else, but I think that this is because of the penetrability of the drug inside the tuberculation.
Yeah, so yes, makes sense. Makes sense. Raises the anesthetic more effectively compared to lidocaine. Makes sense. Preferred supplemental injections. Actually, intraosseous, intraligamental, and intrapulpal are preferred, and compared to medication, which only increase from 30% to 60%, the success rate of supplemental injections are higher. This is Stabident, used for intraosseous anesthesia. Extib. This is what we use in our department. The key point is the anesthetic should be given slowly here. And another thing is that in the instruction, because I started to use this here in the United States, before I didn't use it, I didn't need it because PDL injection always works, honestly. But here, for the sake of my education, I said that they have it, they use it, let me try it. Okay, but the instruction says that you should insert this sleeve to the distal of the tooth, which is the targeted, which makes sense to me anatomically. However, in the reality, there is usually no place in the distal to put it. This is not a small thing. But people here say that you can do it from the mesial, and it always works. It's common practice that you don't have enough place to put it on the distal of the tooth. I did it on the mesial, and it works. So instruction says in the distal, but you can, if you don't have place and if you would like to use it, you can put it in the mesial as well, to me.
But isn't it traumatic to the patient after the operation is all over? I mean, does the patient have any pain after the operation is
No,
finished?
honestly, I don't know.
Because of the
Because,
injection?
I mean, generally, we ask, I didn't do a follow-up. We do the root canal treatment in a single visit. Here, because there is a pressure on that, now I do this practice as well. So I don't know if there is a difference in terms of post-operative pain between the other, PDL injection or the others. I don't know. But I think it is a pain for the dentist because it's stressful. You can injure the root itself, and you have to be careful. It is more, invasive, actually, from the gingiva still. And I'm not sure if it is really necessary, but it's good to have it on your pocket if you cannot achieve the anesthesia by using the other ways. And what is, maybe we can say, the bupivacaine and antidopacaine? These are more long-lasting local anesthesics with higher dosage concentration of epinephrine, and they are not suggested for intraosseous anesthesia because of the side effects, cardiotoxic side effects, and they don't have any additional benefit. So they're not suggested to use with this type of anesthesia. And success rate is 80% for the first injection, 98% for re-injection. So what you can ask more? Immediate onset and duration is 60 minutes, which is fantastic. And PDL injection, which is my favorite.
We're going to run out of time.
Oh, really?
Just to mention. Yeah. We have no more than 5 minutes to finish with this session. So I think if you have too many slides, we can set up another session for the continuation of our talks.
Yes,
So
we can do that.
it depends on you, actually. So if if you're ready. So we are still with you, but because our residents will have their second session of their visits, and their patients will enter the clinic in 2 or 3 minutes
understand.
time. So we have to finish it with today. So just we have less than 5 minutes time. Just go ahead.
Okay, then after 5 minutes, please let me know when we can leave it here, and we can do another lecture with the rest of the slides, okay?
Okay.
And of course, with the PDL injection, we need a specific device, pen holder grip syringe, or I will show you Ligmajet. In the United States, they like it, like a gun type, similar thing. But the idea is you need to give a back pressure to get the anesthesia. Mesial or the distal of each root, you should put 1 to 2 millimeter into the PDL and with back pressure. Blanching of the gingiva is the verification of what you are doing correctly. Pressure is important for the success. And 0.2 milliliters per injection with this. And half a cartridge for single rooted, and whole cartilage is multi-rooted. For multi-rooted is suggested. And Ligmajet, this is what we use here. Success rate is 75% for the first injection and 95% for re-injection, which is fantastic. Onset is less than 30 seconds, duration shorter than 60 minutes, which is not a big deal, you don't need more. And 1/4 of the patients report that their tooth feels high in occlusion. This is the side effect. Pulpal anesthesia is not achieved despite of intraoral osseous and PDL injections in 5 to 10% of the teeth. So, this is an indication for intrapulpal anesthesia. It is used as a last resort because it causes pain. It's painful for the patient. However, it has an immediate onset. Duration is only 15 or a little bit more, 15 to 20 minutes. Goal gates, along with premedication, is described as the best method for effective management of acute pain in irreversible pulpitis. However, inferior alveolar nerve block plus go gates is better than each technique alone. Slow onset, 5 to 25 minutes, you have to be patient. However, the side effect is more positive aspiration of hemorrhage. So, and this is another trivia because I was expecting that they're allowed to open their phones and join me. So if you want, we can stop here. And next time I will take out these questions as well to
Yes,
make the
thank you.
things shorter.
Thank you very much. That was very interesting, actually, because of your collection of nice evidence for your lecture. Everything was evidence-based, everything was based on updated literature, and that was interesting for me, actually. And I updated lots of my false beliefs, actually, about local anesthesia. Thank you very much for your
Thank you.
informative lecture. On behalf of Tehran University of Medical Sciences, you are given a certificate for your presentation today, and I will just show it to you here now, but I will send it to you via WhatsApp or email if you would like so. And of
Appreciate
course,
it.
we're very eager and very enthusiastic to have your continuation of your lecture in our upcoming mutual time. So we will set it up privately and we will publicize it.
Okay.
And of course, we will have a better IT background for this communication. I think it's really valuable for us. As a last question, is it possible for us to have any kind of research collaboration between us and your university? Is it possible?
If you're asking for LSU, I can
Mhm,
talk Dr. McMullen about this, of course.
mhm.
But privately, we can talk about the subjects, research questions, what can they be, because they don't have whole research lab limited, so they cannot test everything. So let's talk about privately. So if
Yes.
they have enough laboratories and whatever, why not?
Thank you very much.
But if you're asking for Yeditepe, for sure, I can say that for sure.
Thank you. Sure.
Do you want me to stop sharing?
Yes, please, for a while. Please stop sharing.
So that you can share yours, or just
Yeah.
you can show me if you want, or you can just send me email.
Oh, yeah. Here's your certificate, actually,
Oh,
and we will send it to you
very
by
smart.
email or WhatsApp. This is actually the beginning of our collaboration. I think it was wonderful for me uh, as a student in your class. And of course, I'm sure that my residents were really eager to continue this chance. Actually, I received a lot of feedbacks, positive feedbacks from different universities as well.
Oh, really?
Thank you very much for your
Great to hear
time.
that.
Thank you very much for your time. Thank you very much for your cooperation. I know that it's very hard for you to cooperate with us at this time at your midnight, and it actually interferes with your rest. But it's our pride and our honor. Thank you very much. Thank you very
It's
much.
my honor. It's always, no matter what day it is, what time it is, it's my honor to contribute Tehran University of Medical Sciences, such a valuable and distinguished institution. Thank you very much.
Thank you very much. That's very kind of you. Bye for now, and I hope to see you soon, actually, for our continued sessions.
Okay. Thank you.
Bye.